Welcome to Around the Couch, a podcast by Kidney Couch. I'm Alex, sitting in for Jeff Callis, founder of Kidney Couch. In this episode, Jeff tackles the complicated, confusing, and many times unsettling topic of kidney cancer recurrence, metastasis, and overall survival rates. It's easy to get lost in the weeds when talking about survival rates, but it's a conversation many patients facing kidney cancer want to have, as unpleasant as it might be for some. Some patients only want to hear from their doctor what the bottom line survival rate is. No details, just the bottom line number. For other patients like me, that's not nearly enough. I need to know the details about what my odds are. To put things into perspective, when I first learned that there was a mass in my kidney that measured 5 centimeters, based on the CT scan and a biopsy of the kidney, my doctors thought the mass was contained to the kidney itself and was likely grade 1 to 2. Given that diagnosis, I would have surgery to remove the mass and go on with my life, just a speed bump that would soon be behind me. The likelihood of the cancer returning was between 1 to 2%. Those were odds I could live with, for a long time, hopefully. But once the pathologist had the kidney in his hands and cut a little deeper, the diagnosis changed from stage 1 to 2 and grade 1 to 2 to a much more concerning situation. It was no longer just a speed bump along the road, more like stopping traffic. After all the pathology tests were done, the final diagnosis was stage 3, grade 3, with renal vein invasion. I went from a 1 to 2% chance of having cancer return to 25 to 40%. Now I was paying attention. There was no way I was going to settle for a little conversation about the risk of the cancer returning or how long I was expected to live. I wanted and needed the details. My urologist ran the numbers in the Leibovich model that makes 2 calculations. 1. The likelihood of kidney cancer recurring, and 2. My cancer survival rate. This is the estimated number of years of not dying from kidney cancer. Both percentages are measured over 5, 10, and 15-year periods. The calculator spit out the chances of my remaining kidney being cancer-free within 5 years at 75%. In 15 years, the chance of being cancer-free was 61%. These numbers are a far cry from 1 to 2%, even 5%. But I quickly found out that these numbers can be very confusing and are often misunderstood. They can also be misleading. The big qualifier is that these numbers are not specific to me. These are estimates from studies conducted with patients with kidney cancer cases like mine. Like me, but it is not specific to my case. I asked my urologist, Dr. George Chow at Mayo Clinic, Rochester, to go over my numbers. It was during that visit that he introduced me to the renal cancer calculator that uses clinical and pathologic features to predict progression-free survival and cancer-specific survival for patients who have had a nephrectomy. The calculator is called Prediction of Oncologic Outcomes in Renal Cell Carcinoma After Surgery. It is commonly referred to as the Leibovich Model, named after Dr. Brad Leibovich from Mayo Clinic. The calculator was developed by Mayo Clinic as a prognostic model for progression-free and cancer-specific survival in patients with clear cell renal cell carcinoma, papillary carcinoma, and chromophobe carcinoma. The model is for patients who have had a partial or radical nephrectomy. Dr. Chow explained to me that rather than using cancer stage alone to predict the prognosis for patients, the model incorporates other important factors to consider, including clinical presentation, histology, grade, and associated findings, such as the presence of histologic tumor necrosis or sarcomatoid features. It was noted that limitations of the model developed by Mayo Clinic include that it is a single-institution study, Mayo Clinic. There has not been external validation of the study, and it is retrospective in nature, a look back, if you will. Nonetheless, Mayo Clinic has been using the model for about 25 years. The model is specific to patients with renal cell carcinoma, kidney cancer. The calculation includes 14 data points. In addition to the calculations from the model, physicians draw on their own experience and those of their colleagues when considering a patient's case to the estimates from the model. One big qualifier for all prognostic models in predicting the return of cancer or survival rates is that the models are usually based on patient outcomes that are at least 5 years old. The models use data over a 5-year period to arrive at the estimates generated. It's a generally accepted timeframe for evaluating patient data for predictive models. It does, however, mean that estimates are based on people diagnosed with cancers of the kidney prior to 2020. Advances in treatment have been made since then. It's these percentages that give me and many other patients scanxiety. Scanxiety, anxiety on steroids. A couple of weeks before a scheduled CT scan, during the scan and waiting for the results from the radiologist can create a great deal of anxiety. It's not like you are just stepping on the scale and hope the box of chocolates you devoured didn't stick to your ribs. You are waiting for confirmation that kidney cancer did not show up near the site of the surgery where the tumor was removed, or that it didn't spread somewhere else, usually to the other kidney, your lungs, bones, lymph nodes, etc. It is nerve-wracking as hell. The hospital staff know from experience that there is a lot of anxiety and can probably feel it emanating from you, and they really do everything to put you at ease, the nurses and radiology techs. That being said, I prefer to have a better estimate of the chances of kidney cancer returning or whether I will die from cancer within 5 or 10 years than have nothing at all. The models look at patients similar in clinical presentation. For example, my estimates are based on patients who were stage 3, grade 3, with renal vein invasion. It's an estimate, not an absolute number. No two patient cases are exactly alike. They may be very close, but not exact. New treatments may also have occurred within the 5 years since the data was last loaded in the prognostic models as well. Getting your numbers from the prognostic model is the first step. The next challenge is to understand what the numbers mean and what they don't. There are several prognostic models that have been developed specifically for renal cell carcinoma, kidney cancer. However, they don't all provide the same output. You have to dig deeper into what each model measures, or you can really go down a rabbit hole. Let's take a closer look at how the Leibovich model is used. I discuss this model because my urologist uses it in his practice. This model measures recurrence and cancer-specific survival. It does not measure overall survival. Other kidney cancer prognostic models do measure overall survival. As with other models, the Leibovich model is used to help in guiding patient counseling and identifying patients at greatest risk of disease-specific death or recurrence. As the American Cancer Society states, kidney cancer prognostic rates, or 5-year survival rates, are statistical averages that predict the likelihood of surviving for at least 5 years after diagnosis, and they vary significantly by stage. For the Leibovich model, the 5-year clock starts at the point where the pathologist has provided the final diagnosis after a nephrectomy, partial or complete removal of a kidney. The American Cancer Society emphasizes that survival rates can give you an idea of the percentage of people with the same type and stage of cancer will still be alive for a certain amount of time, usually 5 years, after they were diagnosed. They can't tell you for certain how long you will live, but they may help give you a better understanding of how likely it is that your treatment will be successful. It's important to consider the following in understanding the numbers. 1. People now being diagnosed with kidney cancer may have a better outlook than numbers generated by the prognostic models show. 2. Treatments improve over time, and these numbers are based on people who were diagnosed and treated at least 5 years earlier. 3. These numbers apply only to the stage of cancer when it is first diagnosed. They do not apply later if the cancer grows, spreads, or comes back after treatment. 4. The estimates don't take everything into account. Survival rates are grouped based on how far the cancer has spread, but your age, overall health, how well the cancer responds to treatment, and other factors can also affect your outlook. That's a lot of qualifiers to be sure. Nevertheless, I'll take the best available estimates rather than throwing up my arms and say, I don't have a clue. In its simplest terms, a cancer survival rate means that a percentage of people diagnosed with a certain cancer are still alive 5 years after their diagnosis. The prognostic models calculate the percentage for specific cancers based on stage, grade, and other factors that are loaded into the models. According to the National Cancer Institute, cancer survivorship starts the day someone receives a cancer diagnosis. It continues during and after treatment and on through the end of life. For patients diagnosed with kidney cancer, in many cases the only treatment they receive is a nephrectomy, the surgical removal of part or all a kidney. That is true for me. For other patients, their treatment extends beyond a nephrectomy, such as immunotherapy. Let's define the two survival rates used in the Leibovich model. Progression-free survival. Progression-free survival is the length of time after a nephrectomy that a patient remains cancer-free from kidney cancer. Cancer-specific survival, CSS. Cancer-specific survival is the probability of a patient dying from their kidney cancer. Cleveland Clinic explains survival rates as follows. I tailored their definitions to be specific to kidney cancer for easier reference. The four most used survival rates include overall survival, cancer-specific survival, relative survival, and disease-free survival. Overall cancer survival rate is the percentage of people with kidney cancer who are alive 5 years after their diagnosis. This includes people with kidney cancer that is in remission, meaning they don't have symptoms, and tests don't find signs of kidney cancer. It is also commonly referred to as all-cause survival. In other words, the overall kidney cancer survival rate is the percentage of people with kidney cancer who are likely to live for at least 5 years after diagnosis, compared to people in the general population without cancer. Your 5-year relative survival rate is not an individual prediction, but a statistical average for large groups, and it varies significantly by cancer stage, with higher rates for localized cancers and much lower rates for cancers that have spread to distant organs. The rate is calculated by comparing people with kidney cancer to people of the same age and sex who do not have cancer. The standard is a 5-year survival rate, meaning it tracks how many people are still alive 5 years after their diagnosis. The survival rate depends heavily on several factors, including the stage of your cancer at the time of diagnosis. For example, a person whose cancer is confined to the kidney has a much higher chance of survival compared to a person whose cancer has spread outside the kidney. A person's age and underlying health also impact their survival chances. The younger and healthier, the better your chances of living a longer life after being diagnosed with cancer. Cancer-specific survival rate is the percentage of people who have kidney cancer who are alive within a certain time after their diagnosis, usually 5 years. This does not include people who died from other causes. For example, a person with kidney cancer who had a fatal heart attack would not be included in the cancer-specific survival rate. This is also commonly referred to as cause-specific cancer survival, or cancer survival. The cancer-specific survival rate is the length of time from the date of diagnosis or the start of treatment until death from the cancer itself, excluding deaths from unrelated causes. This measurement specifically tracks deaths caused by the kidney cancer itself, unlike overall survival, which includes deaths from any cause. It provides insight into how well a new treatment works or the likely prognosis for patients with kidney cancer. Relative cancer survival rate compares the 5-year survival rates in groups of people with kidney cancer with people who don't have kidney cancer but who are the same age, sex, and race. The relative survival rate shows whether a specific cancer, in this case kidney cancer, shortens life. For example, a 5-year relative survival rate of 60% means people with kidney cancer are 60% as likely to live for at least 5 years compared to people of the same age and sex without kidney cancer. The relative kidney cancer survival rate estimates how much the cancer increases the risk of death, effectively removing deaths from other causes. It provides a way to compare kidney cancer survival to a standard comparable population. Disease-free survival is the percentage of people who don't have signs of kidney cancer during a certain period after completing treatment. Researchers doing clinical trials measure disease-free survival rates to see how well a treatment works. This also referred to as recurrence-free or progression-free survival. Disease-free survival refers to the length of time after cancer treatment that a patient remains free from any signs or symptoms of the disease. It is a measure of the effectiveness of cancer treatment in preventing recurrence or relapse. This is one of the main outputs of the Leibovich model that my urologist uses. In my case, treatment refers to the nephrectomy I had. Disease-free survival is different from overall survival, which measures the total length of time a patient lives after cancer treatment, regardless of whether they experience a recurrence. Disease-free survival is an important endpoint in clinical trials to assess the efficacy of new cancer treatments and to compare different treatment strategies. This survival rate is the one I'm most interested in. What are the chances kidney cancer will return? I really don't focus on the other survival rates. Unless kidney cancer returns, I'm not too concerned about the rest. As you have no doubt realized, the definitions are confusing, sometimes used interchangeably, and may seem like splitting hairs. The definitions mean more to the scientific community than they do to patients. It's important to understand which progression or survival rate is being used so you don't draw the wrong conclusions. I'm on the same song sheet as my urologist. I don't pay attention to the other models. One is all you need. I think it's a good idea for you to talk to your physician and make sure you are on the same page too. Writing it down for reference also helps. It does for me anyway. Hopefully this overview hasn't left you scratching your head or gave you a migraine. Repetition helps. It's important to emphasize that statistics on the estimated survival rates for people with kidney cancer are only that, an estimate, one data point your physician uses in assessing your medical situation. Prognostic models cannot tell you specifically if your kidney cancer will return or shorten your life. The same is true for your physician. Both base their assessment on experience, theirs and past outcomes for similar patients. It's the best information available. Do some research, talk with your physician about the prognostic model they recommend, and decide if you want to know the results. If you do, make sure you understand which definitions are being used so you are on the same page. Thank you for listening. I'm Alex, sitting in for Jeff Callis from Kidney Couch. Join us next time around the couch.